welcome to Greiner Bio-One Talks. My name is Anna Maria Šimundić, and I am a Global Director for a Medical and Clinical Affairs Department at Greiner Bio-One. And we are here today to talk about the challenges in achieving the accuracy and stability in glucose measurement. And I have a fantastic guest here with me, and that is Dr. Grenache. Welcome.
Thank you for having me.
So Dr. Grenache is a Chief Scientific Officer at TriCore Reference Laboratories in Albuquerque. He has and had in his career many other roles, but what I know is that outside of being a fantastic professional and a scientist, he's also a very passionate photographer and likes to capture the beauty of the southwestern U.S.
Yes.
Welcome, Dr. Grenache.
Thank you very much. It's nice to be here.
So tell us a little bit about your current role and responsibilities and maybe some of the past roles that you had in your career.
Oh, sure. So currently I'm the Chief Scientific Officer at TriCore Reference Laboratories in Albuquerque, New Mexico. We have a research institute that helps in vitro diagnostic companies bring their products to the U.S. market. And so we do the research studies to generate the data they need largely for FDA submissions. But I'm also the laboratory director for our main reference lab, the medical director of immunology, point-of-care testing, and pre-analytics, and a clinical professor of pathology at the University of New Mexico.
Impressive. But you also were engaged in some professional organizations like...
Yeah, I've been very active in over my career in the Association for Diagnostics and Laboratory Medicine, formerly known as AACC. I served as the president of the association during the pandemic, so I like to call myself the pandemic president. It was a very interesting experience, but also quite rewarding.
Well, once again, welcome, and thank you for accepting our invitation to talk about glucose testing. So maybe let's start with some general definitions. What is so challenging about glucose testing? Why are we so concerned about glucose accuracy and stability? And what do current guidelines actually recommend?
Right. So the challenge with glucose testing is that in whole blood, unless it is processed very rapidly, glucose declines at about 7 to 8% per hour that the sample is unprocessed. That's probably a bigger issue when it comes to tests that rely on glucose for making a diagnosis. For example, in oral glucose tolerance testing for either diabetes or gestational diabetes mellitus, where the glucose concentrations at particular time points are after a glucose challenge or glucose load is given. If they meet certain thresholds, then the diagnosis of diabetes is identified. And so stabilizing glucose to prevent its decline has a great impact on the incidence of diabetes diagnosis rates. So stabilizing glucose to prevent its decline is quite important.
How can we stabilize glucose? There are different ways in stabilizing glucose, I guess.
Right. So most ways just for the audience sake, when whole blood is not processed, and by that I mean centrifuged rapidly, or otherwise somehow stabilized, the cells metabolize the glucose. So there are a few ways in which laboratories can attempt to stabilize the glucose, but they are either imperfect or they are impractical. So a common way of stabilizing glucose, when only a glucose test has to be performed on the sample, is to collect that blood sample in a tube that contains sodium fluoride. Sodium fluoride inhibits enolase in the glycolytic pathway. But enolase is an enzyme towards the distal end of that glycolysis pathway, and so It takes time for that inhibition to occur, but there are other enzymes in glycolysis that remain active, and they continue to metabolize the glucose. So that's one way, but it's imperfect because glucose will still decline by 7, 8, 9% over the first hour. And it takes a couple hours for stabilization to be completed. And even then, glucose still continues to decline, albeit at a slower rate. So that's the imperfect way. The impractical way is after the phlebotomy is performed, the sample can be immersed in a ice water bath, a slurry of ice water, for no more than 30 minutes, and then centrifuged to separate the serum or the plasma from the cells. But that is impractical in settings where samples are being collected. Phlebotomists don't necessarily have access to ice slurries, and they probably cannot, in many cases, process the sample within 30 minutes. So that's the impractical version.
That's maybe acceptable way to stabilize glucose in research settings where you have a small volume of samples, but not for a routine lab with a large number of samples coming in.
Exactly. And in my laboratory environment, TriCore is a regional reference lab. We have patient collection centers scattered throughout the state of New Mexico. So the phlebotomists there can process the samples, but they're very busy collection centers. They can't stop and process everything within 30 minutes, and they certainly can't put everything on ice.
Absolutely. Okay, so is there some promising new solution for stabilizing glucose?
Yes, and it's not yet. There is, and it's not necessarily new. It's just not available in the United States. So there is there's a tube that Greiner makes called the FC mix tube, fluoride citrate tube. It contains fluoride, which inhibits enolase, which is the downstream enzyme. But it also contains citric acid, which acidifies the sample and inhibits two other glycolytic enzymes that are further upstream of the glycolytic pathway, hexokinase and phosphofructokinase. It also contains EDTA that chelates the magnesium, which is a cofactor for enzyme activity. So the beauty, and this has been shown several times over many peer-reviewed published studies, is that a blood sample collected into this tube instantly stabilizes the glucose at its concentration, and it does not decline over time. So it makes it, and it doesn't require rapid centrifugation. It doesn't require the sample to be put on ice. So it addresses both the current impractical and imperfect ways of stabilizing glucose in blood samples that we have access to today. Unfortunately, that type of tube is not currently available in the United States.
So how do you then handle glucose samples in your lab? How does it work in your lab?
So when we collect samples, again, I'm going to be focusing largely on samples, blood samples we collect as part of oral glucose tolerance testing. I'm not going to address glucose as it is in many other chemistry panels, like a comprehensive metabolic panel. So currently, we allow both the impractical and the imperfect options. So if a patient presents to a TriCore collection center, then our preferred method is to collect samples into a sodium heparin tube and process this. So phlebotomists collect into that tube, and then we ask them to have processed, to have centrifuged the sample within an hour. We can't manage 30 minutes. It's just not practical. And we don't usually have access to ice. So the best we can do is to do that. Alternatively, they can collect into sodium fluoride, but we've done some internal studies which have compared both approaches, and we actually get better stability for glucose if they collect into the sodium heparin tube and centrifuge within an hour, compared to collecting into sodium fluoride and not centrifuging it at all.
So I guess you're receiving many samples from distant sample collections.
Yes.
So how do you then handle glucose samples, stability during transport? How do you...
Right. So what's very common So we also have patients that will be collected by, not by a TriCore phlebotomist, but by the client location. They might do their own blood collections, in which case they usually collect in sodium fluoride. But to answer your question, when samples are collected at great distances, if it's at, again, a TriCore collection center, they will have processed the sample, separated it in a gel tube within 60 minutes of collection. So we'll get the processed tube sent to the laboratory for glucose testing. If it's collected into sodium fluoride, there's no gel. So they're not processing the sample and making an aliquot. We are receiving the whole blood uncentrifuged sample in our core lab, which could take 12 hours after it was collected for all the samples to be collected and then transported many hours through the state of New Mexico to reach the laboratory. That's why our preference is to collect currently into the sodium heparin tube with a gel and centrifuge that within 30 minutes rather than the sodium fluoride. We will accept sodium fluoride, but we tell our clients that our preference is the sodium heparin.
And let's talk about the decision limits for diabetes mellitus diagnosis. You were saying that, there are different ways to stabilize glucose, and not all of them work with the same, so to say, speed, right? And so how do we then, how can we use same decision levels if we actually measure glucose with different accuracy?
Right. I think this is the most challenging aspect of laboratories considering using a tube that instantly stabilizes glucose if and when it becomes available in the U.S. and perhaps it is available outside the U.S. So this is the biggest issue. But I think first we have to acknowledge that there are different ways of going about doing, say, a glucose tolerance test for gestational diabetes mellitus, right? So there are two approaches. There's the approach that's been in place for the past many decades. You start with a glucose challenge test, a screening test, non-fasting state, 50-gram load. Person has a blood sample collected 1 hour after consuming the glucose, and if it's above a certain threshold, which varies between 130 to 140 milligrams per deciliter, then it's a positive screening test, and they would go on to have a 3-hour fasting 100-gram oral glucose tolerance test for the diagnosis. The cutoffs for that approach were established many, many decades ago on a very small number of individuals, and in those trials, outcome was based upon the probability of the mother developing overt diabetes after pregnancy. The cutoffs that we use for the traditional approach have been modified a couple times over the past decades. The first change to the cutoffs came when laboratories started testing glucose not in whole blood, but in serum or plasma. They were modified because of the change in concentration when you're measuring glucose in those different matrices. And the second change came when laboratories began measuring the concentration of glucose using enzymatic methods, not older chemical methods. So let's keep in mind that the cutoffs have already been modified from their original state twice. Further, there are two sets of cutoffs that can be used, at least I'm familiar with them in the United States, the National Diabetes and Data Group cutoffs, and then the Carpenter and Coustan cutoffs. So there's already a variety of cutoffs that are in use. And using them, either the NDDG cutoffs or the Carpenter and Coustan cutoffs, have a dramatic impact on the prevalence of a gestational diabetes mellitus diagnosis, on the prevalence of that. The other approach, which is more recent, was developed from the HAPO study, the Hyperglycemia and Adverse Outcomes in Pregnancy study. In that study, the samples that were collected were processed by the impractical method, right? That I say impractical because labs really can't do it. So whole blood was collected into sodium heparin. They were placed in ice, and they were centrifuged within 30 minutes. That is as close to almost perfect as we can get, as almost perfectly stabilizing the glucose as we can get.
As close to the
As close
true
to the
value
yes,
of, yeah.
exactly, as close to the true value. So I contend that if a laboratory is utilizing the 2-hour 75-gram test, oral glucose tolerance test for gestational diabetes mellitus, changing to the FC mixed tube is completely appropriate. There's no adjustment to the cutoffs that I think would be needed. I think it's much more challenging for the traditional approach, the 50-gram screen, the 100-gram diagnostic, which is still very commonly performed, at least here in the U.S. In that case, I think we have to acknowledge that switching to an FC mixed tube would result, A, in higher glucose concentrations because of the good stabilization, and that would increase the prevalence or the incidence of a gestational diabetes mellitus diagnosis. But I think we have to ask ourselves, is that acceptable? So based upon recent experience at TriCore, I would say that it probably is acceptable to many physicians. I think laboratories would have to have that conversation. At TriCore, for many, many years, at least since I've been there, we have always used the NDDG cutoffs for the 100-gram, 3-hour oral glucose tolerance test for gestational diabetes. But after many requests to change them to the Carpenter and Fustan cutoffs, which are lower, we made the change. And the incidence, if we're just looking at our own data, we have doubled the incidence of a GDM diagnosis just by changing from NDDG to Carpenter and Fustan cutoffs. And no one has complained. This was wanted by the community. So a laboratory that would be considering changing perhaps to the FC mixed tube to instantly stabilize glucose and give a more accurate glucose result, I think you just have to have that conversation. First of all, do some studies to determine what the impact might be. They don't have to be large. They can be pretty small. And then have a discussion with the clinicians who would be affected and whose patients would be affected by such a change to get their feedback. I've always contended that as laboratory professionals, it is our responsibility to provide laboratory data that we know is accurate. And we know already that our current methods of stabilizing glucose result in glucose results that are not necessarily accurate. So we should be utilizing technologies and methods that give us the best accuracy.
Yeah, but you said that, it's up to the laboratory. And I'm wondering, isn't that maybe too big of a responsibility for an individual lab to decide on, which way to go? So I'm just wondering, is there maybe a need for some professional consensus? Because we need some kind of standardization globally, right?
Well,
Shouldn't...
There already are guidelines and recommendations that clearly state that a tube like sodium fluoride is insufficient and that laboratories should use a tube like the FC mixed tube for these types of glucose measurements. So those statements are out there. It is a big ask for an individual laboratory to make the change. But again, you have a conversation with the people who utilize the laboratory, get their feedback, and then make that collaboratively. I wouldn't advise a laboratory to make this change independent of the clinicians who utilize those laboratory services. But I think an effort to get broader consensus is certainly a good one, a little more challenging to do if you want to go beyond the scope of what your own laboratory does. But I'll repeat that already there are guidelines that clearly state that the current methods we have of stabilizing glucose are inadequate or imperfect.
Is there a role for potential for citrate tubes beyond glucose?
Probably, right? Because there are several analytes that we know aren't particularly stable. Lactate is often identified as one of those. So anything that homocysteine is another one. If the quality of the sample, if the acidification and the presence of fluoride does not affect the measurement method, but it does stabilize, the analyte, then sure. I think there is potential applications. They just have to be explored. I'm not as familiar with what work has already been done on with the FC, a tube like the FC mixed tube on analytes other than glucose.
Thank you. Well, this has been very exciting. Thank you for sharing with us your thoughts about glucose accuracy and stability. So my last question for you would be on a more personal note. You had an amazing career, and I understand that you are retiring by the end of this year.
I am.
So looking back on your career, and in particular on pre-analytical issues in your lab, what was the most memorable moment in your career, most memorable pre-analytical moment from a patient's perspective?
It happened early in my career. I was completing my training as a clinical laboratory scientist. I was still a student. And in the late afternoons, I was a phlebotomist in an outpatient collection center in the hospital that I was doing my training at. So this was very early in my career. And I was just learning phlebotomy. But in the outpatient setting, most people are relatively easy to collect blood from. One afternoon, and I was all alone, no backup. A gentleman came in who was an IV drug user, and I tried phlebotomy on his veins in his arm, but I was not successful. And after 2 attempts, we were instructed to stop trying and call for help, but I had no one to call. So I told him he was going to have to come back another day. And he said, well, I can do it. If you just give me the tube and the needle, I can get the blood for you. And I paused because I thought, I don't think I'm supposed to do that. But I said, give it a try. So I gave him the needle in the adapter and the tube, and he proceeded to puncture his jugular vein right in front of me. But he got the blood sample. And after that happened, I thought, I'm not going to tell anyone that this just happened, although now I have told everyone. And I'll never do that again. So that was very memorable. That is a
memorable moment. I agree. Well, thank you once again. It was really exciting to learn about your thoughts on glucose measurement. So with this, we will end this podcast. Thank you for being with us, and I hope you have enjoyed this episode as much as I have.